Hi, everybody. Welcome to SimiTree's webinar. We're really excited to have you here today. We're going to give everybody just a minute to get into the webinar and get their audio up and working. In the meantime, I'm Missy Gilliland, the Director of Learning and Development. We're very glad you could join us today. If you have any questions as we go through the webinar, please feel free to use the Q&A. We're going to save some time at the end to answer any questions. And if we don't get to them this afternoon, we'll make sure that we send a follow-up email. Again, we're really glad that you guys could join us today. We're giving everybody just a second to get in and get logged in. Today, we're going to cover the home health proposed rule. We've got some of the best experts in the business here to talk you through it. With that, I'm going to go ahead and turn it over to Jnon to introduce herself and get us started.
Thanks, Missy. Hi, everyone. My name is Jnon Griffin. I'm a registered nurse, been in the industry a long time, 30 plus years, and I'm the principal over the coding and OASIS department. Rob?
Thank you, Jnon. Thank you, Missy. I'm Rob Simione. I'm a CPA and a principal at SimiTree. Been in the industry now 16 years and oversee our consulting team at SimiTree. Pass it to Brian.
Thanks, Rob, and good afternoon, good morning, everyone, depending on where you're dialing in from. My name's Brian Harris. I just passed 12 years in the industry, and I'm a consulting director on our finance and revenue cycle consulting team. So excited to be talking with you all today, and we can dive in and kind of look at a high level of the proposed rule here. So our main focus of today is really to look at what can we do to prepare for all the things that we're about to talk through. We could spend a half hour just talking about specific sections of the rule or points of the rule. We're going to hit those pretty quickly and at a high level, so please feel free to throw questions in the chat or at the Q&A at the end if you want to go over anything in detail. But we really want to focus on, okay, what happened in the proposed rule is a lot of what was expected, specifically with what we're about to run through with the reimbursement changes. So we're here, we're living at this point in time. A lot of things we've been talking about in prior webinars and prior years of the behavioral adjustment and VBP and Medicare Advantage, we're kind of past the point where it's, hey, this is probably coming in the future, and we're at the point where it's here, and we need to either prepare or start operating understanding that. So we're going to run through a lot of this and really try to round out the conversation and hopefully the Q&A with the conversation, with a discussion on how do we adapt to these changes that are now here and that we're facing as a home health industry. So if you look at the 30,000 foot view of the summary, there's an estimated $375 million reduction in global spending in the proposed rule coming in the form of a 2.2% rate cut. We're going to go through that a little bit. Obviously, the big factor there is the behavioral adjustment that Medicare continues to apply to these rules, but obviously raises a level of concern just in terms of the reimbursement rates. We will also talk through the PDGM recalibrations of case mix weights and specifically some things that we're seeing with wage indexes that are occurring that are in conjunction with that 2.2% rate cut and along with the changes in the base rates from the behavioral adjustment. We're going to look at some revisions of value-based purchasing. Obviously, we're in the first performance year now. There's going to be some changes coming in the 2025 performance year. So we're going to take a look at that. Again, much further discussion to be had moving forward there, but definitely some interesting changes. Take a look at some of the additional measures being added to the quality reporting for 2025. And then just in the proposed rule itself, there's a lot of talks of updates to the reimbursement rates, billing structure, a few things about the home IVIG, DME, the pressure wound therapy. So we're not going to go into that in too much detail here. There's a lot that you can read into in the rule. But again, if you have any specific questions, please feel free to throw them our way throughout this discussion. So starting with the big update, and again, this is not wholly unexpected, even if it is still disappointing, but there's an anticipated 2.2% rate cut that's coming to overall spending. And really the crux of this is the behavioral adjustment. Now, I'm sure you've heard a lot about this over the course of the past few years, but really this is CMS's approach to looking at, since the change to PDGM, how is spending on the home health benefit versus what spending would have been if we had stuck under the 60-day episodes and PPS. So you've got the permanent adjustment and the temporary adjustment. The permanent adjustment is essentially what CMS believes the changes to the base rate need to be in order to keep things budget neutral in terms of spending moving forward. The temporary adjustment is CMS's methodology to say, we feel like we overspent in 2020, 2021, and 2022, and at some point we need to claw those dollars back. So if you look at the chart that we have down here below, you'll see the permanent adjustment, and this is all numbers from the proposed rule, came to around 9.36% in total over those 3 years. Now, don't want to get you lost in the math here. We're going to kind of jump to the summary on the next page of the actual impact here, but this is what CMS is looking at and saying, and sorry, Missy, if you don't mind jumping back for 1 second to the last slide. Apologies for the leading cues there. So that is what in terms of, hey, we need to change the base rate by this amount in order to kind of fix things, quote unquote, moving forward, let alone some of the disagreements that we as the industry have with that. The temporary adjustment you'll see is close to $3.5 billion that they feel that they overpaid in spending over these 3 years. Now, this doesn't factor in the first part of the behavioral adjustment that they took for 2023. This is just the aggregate of everything and what they're looking at from 2020, 2021, and 2022, using 2022 claims data available to date and 2021 cost reports. So now we do jump to the next slide. There are several pages worth of actual math and calculations to how we got here in the proposed rule, but at the end of the day, the proposed permanent adjustment that's being applied to the rates for 2024 is a decrease of 5.653%. So again, we'll skip past all the math as to how we got there, but that is the main impetus for why we're seeing the estimated overall 2.2% decrease in spending. In reality, that actually becomes 5.1%. So everything with the behavioral adjustment does not apply to the LUPA rates. You'll actually see that LUPA rates are going up by 2.8 percentage points. This is really to the base rate as you see it below. So once you factor in this permanent adjustment and all the different case mix recalibrations, budget neutrality factors, all the items that you see below, the national standardized base rate is dropping from 2010 69 in 2023 to a proposed 1974 and 38 in 2024. So this would be the lowest rate that we've seen since 2021, with the main driver being that change from the permanent adjustment. What's important to note here is that CMS is not touching the temporary adjustment at all. By making this proposed 5.653% change, they believe this will get us pretty close to a point where in future rules, the permanent adjustment should play a much lower factor and not be as looming. That being said, they still have language in there that they're talking about potentially through the year 2026 to claw back that temporary adjustment, which they view represents close to $3.5 billion in total spending. So again, we could dive into that, and we will in future discussions and videos that we release, but know that they're looking to apply the remainder of that permanent adjustment that they didn't put into play in 2023, but have not yet touched the temporary adjustment. Expect to see that in future years, and this is the overarching result on the base rate. So we jump to the next slide here. Did want to talk through some other items outside of just the behavioral adjustment component. Really recommend paying attention to changes in wage index. If you dive into the files for 2024 that CMS released, which is available on their website, compared to 2023, we ran some quick numbers. The average change for urban CBSAs is a decrease of 0.6%. The average change for rural CBSAs, decrease of 0.9%. And you'll see, if you look at the CBSAs receiving a decrease in wage index, it far outweighs the number of CBSAs receiving an increase in wage index. And there are actually 45 urban CBSAs and 3 rural CBSAs incurring the max capped 5% reduction. So if you recall last year, CMS put in play that wage index couldn't be reduced by more than 5% in a given year. Last year for 2023, we saw 13 total CBSAs impacted by this max, hitting that max 5% reduction. This year, it's a proposed 48. So there are some pretty significant fluctuations, especially decreases in the wage index, that on top of the behavioral adjustment, you're going to want to make sure you're paying attention to your region and what the impact is there. Now, as part of the calculation of that, the labor-related share, so basically the portion by which the wage index impacts rates, is dropping a little bit from the 76.1% to 74.9%. So that does soften the blow a little bit of the wage index decreases, but it really only mitigates that by about half. Ran a few mock scenarios, and some of what we were seeing is if your wage index was dropping by 2%, the changes in the labor share made it an effective 1.2% drop. So it's still decreasing. It doesn't completely weigh it out, but it does mitigate the impact of that a little bit. We mentioned that LUPA rates are going to increase by 2.8%. They are decreasing the fixed dollar loss for outlier in order to achieve that benchmark of where they want to be spending on outliers from 0.35 to 0.31. Effectively, that means there's more periods that will qualify as outliers, but there will be lower outlier payments per period. And important to note, so the penalty for not submitting quality data remains at 2%. Wanted to call that out because in the hospice proposed rule, they're proposing to increase that to 4%. We have not seen similar language in the home health proposed rule, so did want to call that out as well. If we jump to this next slide, just wanted to give a visual here of the CBSAs that we mentioned are incurring that 5% wage index reduction. And again, these are specific CBSAs, not states as a whole. But again, just want to call it out. You'll see this is pretty widespread. It's not just a couple of states that are really being impacted by this. So you really want to make sure you're looking at that data that CMS has available and look at the impact to your region overall. We jump to the next slide as well. One of the things that CMS is really paying attention to is visit utilization. So we want to touch on that over the last couple of slides. And again, the proposed rule contains a lot of information regarding this, but part of the impetus and one of the factors in the proposed rule is looking at a decrease in visit utilization, which CMS then ties to a decrease in average cost per period. So really important to take a look at that. You'll see it's kind of across the board. This is looking at actual data from 2020, 2021, and 2022 versus simulated period data in 2018 and 2019. If it had been under PDGM, you'll see the average is going down and has dropped pretty notably compared to the simulated for 2018 and 2019. It is interesting to note they call out a lot about the total therapy visits being down, and they certainly are from 2018 to 2019, but you'll see it has kind of stabilized and has even ticked up a little bit over the last year or two. So did want to call this out. Again, we could have a much larger conversation and the rule goes into in a lot of detail, but this is really something that CMS is looking at when they're looking at the behavioral adjustment, cost per period, and rate setting here. And they're using that with a lot of what we're looking at. One interesting point that they call out therapy a lot, but did want to pull out this table directly from the rule. The percentage of therapy-only cases has actually gone up over the last few years to close to 20% of home health periods are therapy only. So there's a lot of data that's out here. We're admittedly still digesting some of it ourselves, but really focusing in on the therapy cases because it seems like CMS is talking about those a lot, especially knowing that the therapy weighting to the HIPS code, it was taken out heading into PDGM. Definitely something to pay attention to because we know CMS is looking at it. Along with, if we jump to the next slide, CMS actually put out a request for information on home health aid utilization. You'll see that the average visits per period has dropped pretty steadily from 2018 to 2022. So there's a lot of factors. Again, we can jump into a much deeper conversation about that. I'm sure we will at later points, but that is something that CMS specifically spent a few pages of the proposed rule calling out is why is that decreasing? Do we feel like patients still have the access they need to? Is it that there's more dually eligible patients and more of these aides are going to Medicaid? Again, much larger conversation we can have, but if you take anything away from this, it's that CMS is really paying attention to visit utilization. If you jump to, we have one more slide on the visit utilization here, specifically with LUPAs. Again, this is directly from the proposed rule. You will see that LUPA rates, again, 2020 was the first year of the pandemic, but LUPA rates have actually gone down a little bit, resting kind of around that 7.9% to 7.8% that we see here, if you look at the periods that are qualifying for LUPAs. So again, move through that pretty quickly. And really want to take away the visit utilization that we're looking at here. CMS specifically calls out in the proposed rule that some of the numbers that you've seen in the last couple of slides and a lot more of what they call out proves that visit utilization is stabilized. I know a lot of the advocacy against some of these rate cuts and some of the things CMS is doing is that the pandemic plays a factor, and we certainly do believe that. CMS's stance is that the data, similar to what we've seen in the last few slides, shows that visit utilization patterns are stabilizing in 2021 and 2022. So that warrants using that claims data for future rate setting and for future understanding of cost per visit and visit utilization. So it's definitely something that I'm sure there'll be further conversation on. But really wanted to lay that out before we dive into some PDGM specific factors here. And again, we're going to go through some of this in specific of the recalibration, some of the things that they're changing and some of the rate impacts here. We don't intend for any of these rate discussions to be doom and gloom, but we want to make sure that we're putting all this out here to understand that there is a level of concern in what's happening with these rate changes, and it's not just the behavioral adjustment. So we really need to be paying attention to that. And again, want to round out today's conversation with this is here. What can we do to try to mitigate it? So if we jump into the first slide here, specific to PDGM, again, just want to take a look at some of the analysis here. It's based off of 2022 non-LUPA claims data. It's really through Q2 and a little bit of Q3 at this point. So by the time the final rule comes out, the hope is that they have most, if not all, of 2022 claims data. Probably won't be fully there, but they'll have more data to work in that could impact some of the changes that we're seeing here. But they're using the most recent, which is about halfway through 2022. 2021 cost reports are the latest that are being utilized here. You'll see there, CMS is showing that the base rate that they used in 2021 and 2022, well above the average cost per period that they estimated. So again, that's what they're looking at in substantiating some of these rate cuts that they're talking about here. And we made the comment earlier that based off some of the data we're looking at, that CMS is utilizing with this claims data and cost report data, that visit patterns have stabilized over the last couple of years, kind of smoothing things out coming out of the public health emergency. So I will say we are still going through a lot of the cost report data that we have available ourselves and intend on putting out some more information as we see notable. We are seeing some pretty substantial increases in cost per visit on the nursing side and early feedback that we've seen from 2022. Not enough where it's finalized, but as always, what we talk about with advocacy, the more we can put data behind it, the more hopeful that we are that we'll be able to claw some of this back. So if we jump to the next slide here, if you look at changes in clinical groupings, the table that you have on the left are the clinical groupings that are going to be experiencing a recalibration that shows a overall average decrease in the case mix weight. The table on the right is going to be everything that's showing an increase. So the notable piece about on the left, outside of the wounds, but the ones that are really seeing the heaviest decreases are your therapy heavy clinical groupings. So kind of ties into the therapy utilization that we talked about, that drop off that we've seen over the last couple of years compared to what was simulated for pre-PDGM. But interesting to see, if you look at average case mix weight for these clinical groupings, it's the therapy heavy cases that are really getting hit. And overall, the changes in case mix weights represents about a 0.1% increase. So if you look at the overall decrease in global spending, the PDGM recalibrations are going to hit certain areas, but overall aren't really the main factor for that. So did want to call that out specific to the clinical groupings. If we jump to the next slide, looking at the functional impairment level, and Jnon, I'm going to toss it over to you in a second to go through some of these specifics of this. But reminder with the functional impairment levels, CMS's goal is to get a third with low, medium, and high here. They've slowly started getting back there. It was a little bit more out of whack than they would have hoped in 2020, 2021. They did some recalibrations over the past couple of years, and you'll see that on the 2022 side, the high functional level is close to 39%, and the medium's around 33%. So they are doing some recalibrations, again, hopefully closing the gap in their eyes to that third that we're looking at. But the recalibrations they've done over the past couple of years have really started that path. And Jnon, I will toss to you to go through some more of the details of the changes.
All right, thanks, Brian. So if we look at the 2024 proposed OASIS points table, you can see what they have proposed for 2024. However, if you look at the right-hand side, you can see that the majority of the changes have gone down. So in addition to going down in the number of points, just like they did last year, they've also decreased our functional thresholds. And so like Brian was saying, they're trying to get the 33 third of low, medium, and high functional scores. If we look at the case mix weight, it's going to go up for the lows, and there'll be a slight decrease for the mediums and the highs. The one area that I can say of the functional points that have gone back up is M1033, risk for hospitalizations. It was at 11 points. Last year it went to 10 points, and it's back to 11 points this year. But everything else, they decreased the number of points. All right, next slide. If we look at the comorbidity adjustments, for our high comorbidities, they expanded the group, the subgroups from 91 to 101 subgroups. They added 3 new low comorbidity subgroups. So that's going to be our GI2, neoplasm 17, which is going to include our secondary neoplasms or of our respiratory and GI systems. And then they added Alzheimer's disease and related dementias, which is the neuro 4. They did also remove proposed to remove 3 low comorbidity subgroups, which was our GI1, which is where our ulcerative colitis, our musculoskeletal 2, which is our rheumatoid arthritis, and our neoplasm 6, which was our neoplasm of the bronchus and lungs. Next slide. Again, comorbidity adjustments, they are a lot like functionals. They're trying to get them into a third of none, low, and high comorbidities. You can see here where calendar year 2022, the majority were in the low comorbidity subgroups. Again, they're trying to make that a little bit more balanced. You can also see the change in the case mix weight. For the none and the low went down and actually went up for the high, but we also know that it's going to be more difficult to get it into the high. So next slide. There we go. Now we're going to talk a little bit about VBP and the changes there. They threw a little surprise in for me anyway. I don't know if it surprised anybody else, but they're talking about moving the baseline year from 2022 to 2023. So just like all of the agencies have gone this year and thinking, okay, well, this is going to be the baseline year. We got our interim report in July. Now they're saying, nope, we think it'll be better if we move that baseline year to 2023. And then you'll get the interim report next July, again, halfway through the year. With that, they are looking to move all of the claims-based measures to 2023. Claims-based measures 2023, except the discharge to community post-acute care. And we're going to talk a little bit about the changes that they're going to have in those discharge patients, and also the claims-based measures of ER and hospitalization is going to go to a potentially preventable hospitalization. So we're going to talk about that a little bit in just a minute. They're talking about removing the measures of the OASIS-based DC to community, but they're talking about moving that to a claims-based measure. And so really it's the same calculation. It's just not based off of the OASIS, but it's based off of the claims data, which is one reason that they are expanding that baseline year for that measure to include 2022 and 2023. Also, a little bit of a surprise to me is they are removing both of the TNC measures, and they're looking to replace that with the discharge function score, which is a new measure based off of the GG items. Again, removing the acute care hospitalizations and the ER use, and doing another claims-based potentially preventable hospitalization measure. And then the measures will be reweighted, and we're going to have a table on that in just a minute to show the removal or the addition of these items. Let's talk a little bit about the discharge function score. It'll be interesting to see how this all plays out, but it'll be based off of the actual way that you're scoring your GG items at discharge. And you can see a little bit of the steps. It's a little bit more complicated than this, and you have to go into wheelchairs instead of ambulation. There's all that, but it's based off of your GG items at discharge. You will have some measure of points if they had an activity not attempted. So if we look at the Impact Act items, which are the GG items, remember it's supposed to be across a post-acute care setting. And really everyone else besides home health is getting measured off of this. And it didn't say this anywhere in the proposed rule. It is just the Jnon philosophy that this is the first baby step that they're making toward paying us off the GG items rather than the M1800 items. So again, don't blame CMS if it doesn't come out, say Jnon said it, but everything indicates that that's the direction they're heading. Again, in a skilled nursing facility, that's how they get paid, is off the GG items in their functional scores. Next slide. A little bit about the potentially preventable hospitalization. It is not only the potentially preventable hospitalization, which is really, really hard to say, but also the potentially preventable observation stays. And so we will look at, it'll be a claims-based measure, and the agencies, again, will have that that ER use and acute care hospitalizations taken away. And these will concentrate on unplanned admissions. So, those patients that have routine surgeries that's scheduled in the middle of their episode, the agencies won't get penalized. But what falls into these categories are inadequate management of chronic conditions. And it doesn't say that, hey, if they have CHF and they were on the way to the doctor's office and they were in a car accident, you're still going to get penalized because they still have CHF. That's a chronic condition. Inadequate management of infections, other unplanned events, and inadequate injury prevention. And these will be based off of those chronic ICD-10 codes and the HCC codes, which we've really not had to focus too much on in home care. That's been reserved more or less for physician offices and for managed care. But the HCC codes are really ICD-10 codes, but they are the hierarchy of chronic conditions. And so each of them have a point. That's actually changing next year too. So they're going to have those chronic conditions, your CHF, your COPD, will be part of those patients. There will be considerations for the number of hospitalizations, ER visits, skilled nursing facility visits within the previous year for each patient. And it's going to exclude those that have occurred within 30 days of the start of care or the resumption of care for that patient. Next slide. If we look, and I said earlier that the weight distributions would change because of the removal of the TNC measures, you will see how the proposed redistributions are with those new measures and then those removed measures taken out. You're still talking about 35, 35, 30 to add up to 100%. But if you look and see how, if you're in a large cohort, which the majority of the country is, if you take away those two TNC items, you will see that was 8.75% of what you had. And what they're going to add then is that discharge to community post-acute care, and that's going to end up being about 9%. And also the potentially preventable hospitalizations, you'll see those points added too. That's about 26% for the large cohorts. Your HCAHPS will remain the same. If we look into the QRPs, there is a proposal of two new measures, one being the discharge function score that we've already talked about, and the other is COVID-19 vaccine, and it's percent of patients or residents who are up to date. And from what I could tell from the proposed rule, it didn't say just had a vaccine. It was talking about the recurring, recommended booster doses for that COVID vaccine also. It will be part of a new measure, just kind of like the flu vaccine is now. As of January 2025, the following two items will be publicly reported. We've been capturing them on OASIS, which is the transfer of health information to either the provider or the patient. They are looking to publicly display these two assessment measures for the previous rolling 4 quarters, starting with discharges April 1st through then March the 31st, 2024. And then again, they're looking to remove the following QRP, which is the percent of long-term care hospital admissions and discharge functional assessment and care plan that address function, and replace it with the new discharge functional item. They also, good news for those of us that look at OASIS all day long, are looking at removing M0110, which is episode timing, and M2200 therapy needs, as there really was no benefit to that after we went to PDGM. They said, some agencies may still have to do that because the payer wants it. We found that pretty much no payer wants that they're either going by the PDGM or they're paying per visit. And so they really don't need that episode timing. And it really was confusing because the payment timing wasn't the same as the OASIS timing, and that was just confusing to everyone. And then health equity, they are considering adding social determinants of health data used by acute care providers in the future. We know social determinants of health have been a big push with not only the coding world and expanding social determinants of health coding, but it's becoming more and more important in your care planning in home health. And Rob, turn it over to you.
Thank you, Jnon. So I hope we didn't make it too doomsday today with all the changes going on. It's hard to go through this and say, oh, we're having another rate cut as an industry, right? We're having a 2% rate cut. Our costs keep on increasing, as Brian mentioned before. A lot of the data we're seeing is 2022 actually cost report data shows some pretty significant increase, especially on the nursing side of things, as well as you're just seeing cost increase in general, as well as other challenges such as payer shifts and other things going on in your market. So as you start to prepare for 2024, really we need to think going forward, right? We can't too much sit back and say, oh, woe is us, we have a rate cut, because if it happens, we need to be prepared and ready for it. So part of this is really preparing for yourself for this and strategically aligning some of your initiatives towards that. So first and foremost, you're probably starting to think about putting together your 2024 budget. Some of you may have already even budgeted out your first 6 months, depending on your fiscal year. So really going through that budget process and aligning your revenue and cost opportunities as an organization is really, really important. We recommend, as you go through this process, really almost create a project type plan where you're going through your different initiatives and saying, here's what I'm going to do to increase my revenue. Here are some opportunities potentially to be more cost effective and efficient. Here's an opportunity to improve my quality scores and all those various areas. So really getting that together for 2024 and starting that process now, right? Because you don't want to start in December. You don't want to start in the beginning of the year because you've already fallen behind. The process of planning starts today for 2024. So as you go through this and you start to think about what are some of the areas, first and foremost, you always want to look at revenue. And I always find revenue, there's always some really low-hanging fruit in terms of revenue. Specifically, if you kind of look at from a revenue standpoint, looking at our quoting, looking at our case weight mix, are there opportunities? What does our documentation look like? Are we truly documenting the acuity of the patient? I've been on enough phone calls over the last 6 to 9 months or even year with Jnon to know that every agency has opportunity. You look at your clinical groupings. Are you coding to the right clinical grouping? Are you documenting to the right clinical grouping? What's your primary reason for care? Looking at your functional thresholds. As we said, there's going to be some pretty big changes in terms of some of the thresholds and scoring on that. Making sure your team's up to date, making sure they have the education on all the different changes there. And then looking also at, obviously, at your comorbidities as an opportunity there too, making sure you're documenting all those secondary diagnosis. And with that, even too, tying it in terms of value-based purchasing. We're within the first 6 months of value-based purchasing, right? We're almost done with our first performance year. You should be taking that information from your Piper reports, really creating a plan to see where there are opportunities for improvement, whether it's providing education for your staff, even talking about, hey, if we're going to be on the right side of value-based purchasing, which all of our goals should be is on the right side of value-based purchasing, how do we make sure that our clinicians are doing the right thing, our clinical managers are doing the right thing, both from the patient perspective and to make sure that we at the end, in year 1, year 2, year 3, and going forward, we're in a good position. Because if you have a 2% decrease now, in 2025, you could magnify that to be a -4% decrease, -5% decrease, depending on where you sit in terms of value-based purchasing. So really looking at some of your initiatives there, regrouping the teams, and finding ways to make improvements there. Second, LUPAs. Brian showed the data. Medicare says you should be at around 8%. There are a lot of organizations right now I see at 10, 11, 12, 13, 14, 15% in terms of LUPA percentage. Really start looking at your processes clinically. Typically, what we see from LUPAs is a heavy amount of LUPAs in the second 30 days. A lot of agencies have figured out the first 30 days. They're avoiding LUPA in the first 30 days. But the second 30 days, and a lot of that is clinical management, making sure you're looking at missed visits, making sure you're looking at when the patient should be discharged, appropriately discharged on this. Are we holding on to patients too long? Are we discharging them too early? Looking at some of those processes within your organization, obviously they kind of collide with the LUPAs and value-based purchasing. We want to have the right mix, right? We want to make sure that we're appropriately caring for that patient, which will drive up our value-based scoring, and avoiding those LUPAs by making sure that we're visiting on time, we're not moving visits back, and really looking at those missed visits and those patients not seen in 15 to 30 days, I think are some of the critical factors. There's significant dollars there if you can take a looper percentage down from about 10, 11% down to 8%. That could offset some of that 2% reimbursement in there. So really looking at those clinical processes. Even to think outside the box as an organization. Are there opportunities to generate other revenue? Look at Medicare Part B outpatient therapy, palliative, hospice. If you don't have a hospice program, is there an opportunity to potentially go into hospice? Look at other ways to diversify your revenue. It helps, one, because you're able to become more of a full continuum of care for your patients and provide more services, really increase your outreach within the community as well. And it's an opportunity to really grow your revenue in other areas in terms of making sure from a staffing standpoint, but also from a standpoint of making sure that there's less risk in all your revenues just in one bucket. Again, that just helps you out from a business model standpoint as well as just offering more services in your community and your referral sources. The other challenge we have right now is Medicare Advantage, and there's no slowdown in Medicare Advantage. We're seeing it increase in some markets. It's almost over 50% now penetration of Medicare Advantage. Many of us are being paid on a fee-for-service basis, which presents its own challenges, right? From a standpoint of making sure that we're getting reimbursed appropriately, which most of us are probably not getting reimbursed appropriately to cover our cost. From the standpoint of also looking at billing and collections, it is significantly more difficult to collect on a Medicare Advantage contract than it is on a Medicare, because you require verification, you require authorizations. More hands need to touch that potential claim before it goes out the door. So it's also increasing your cost infrastructure too. So really from a standpoint of a Medicare Advantage, we're seeing a lot of organizations start to narrow down who are they going to work with in their market, who are the easier ones to work with, who are the ones with better rates, who are the ones willing to pay us potentially on an episodic basis, some that may be able to go into a risk value-based payment model as well on that side of it. And then even looking at our contractual terms, one's our timeliness in terms of from a billing timely filing from a billing standpoint. What are our authorization processes? What are some of the codes we have to set up? Even on that standpoint, one of the most frustrating things we see a lot of agencies do too is they don't set up their codes right in the system or set up their rates right in the system. And that creates a lot of confusion in terms of the billing side of things. In terms of collections, and people are starting to follow up on revenue that's not there, or we're misbilling and catching it later and it's too late, we can't collect on that claim. So again, you want to make sure you really have a good control over that Medicare Advantage business, because again, that's growing part of your organization, and there's potentials just by reducing write-offs there and becoming more effective and efficient in the verification and authorization process, that you potentially make sure you're sending out clean claims as well as collecting on time. Lastly, analyze your market opportunities. The market's changed. It used to be just grow, right? Really what you have to do is look at your data internally and figure out where does it make sense to grow within your market, right? Which referral sources should you be working with? What type of patients? What can you staff, right? Can you staff therapy versus nursing? Can you be more innovative in your care as well? So looking at specific referral sources, looking at specific market opportunities, whether you're a freestanding agency or a hospital-based agency or part of a large network, there are significant opportunities in your market to grow, but make sure you're doing it in a way that makes sense. A lot of organizations, what we see is they want to grow in every which way, right? You want to grow in one market and another market, really focusing more on your core market, right? Where's there an opportunity in your core market? Because what happens when you go into a new market, you have to hire new staff, you have to schedule, all those things become more challenging as an organization on that side of it. So again, maybe a different way of training your sales staff, and maybe a different way of really going out there and looking at the market data internally. And then really one of the areas you really need to focus on too is the cost side of things, right? We have to be as cost efficient as possible now. We're getting reimbursed less and less every year, but our costs are rising. One of the key things, and Brian and Jnon talked a lot about it earlier, is looking at visit utilization, right? So if they're saying we're doing less visits, right, we have to look at how are we doing these visits? What type of disciplines are we utilizing? One of the areas we really recommend specifically looking at is therapy, right? We know that they're starting to decrease therapy reimbursement on a lot of those clinical groupings. So what does that mean? We may want to start looking at models where we incorporate more physical therapy assistants or occupational therapy assistants into our model. Obviously, they're less cost, making sure we're maybe setting up some sort of pod model as an organization where we're utilizing them in some terms of some of the visit utilization, and then letting our therapy managers more case manage those cases, or full-time therapists case manage those cases. So again, look at opportunities from a visit utilization standpoint by incorporating those, but then overall, look at your visit utilization practices. While your visit utilization numbers may be at benchmark or a little bit lower, look at it by clinical manager. There's certain clinical managers that are overutilizing in certain disciplines. You look at the first 30 days versus the second 30 days. There's some great data and tools out there, like Compass from SimiTree, that has that information where you can actually look at the diagnosis, look at the clinical groupings, functional status, and see on average how many visits are these patients getting nationally, to make sure you're in line, right? It's not the exact number, but at least be in line in terms of a general range, and making sure you're not overutilizing it, because you're not getting paid any more from Medicare. In fact, you're getting paid year over year less for those visits. Again, that's something to look at as well. Productivity continues to always be a problem because of staffing and other issues, but really review your productivity targets. You see if they align with your with your quality and financial outcomes, right? Really, what we recommend is more of a model where your nurse case managers are only doing 4.5 visits or so a day, unweighted visits a day, and you're utilizing more LPN and maybe per visit nurses to pick up some of the revisits, or really allowing them to case manage. If they're allowed to case manage, really that we see that there's an improvement in visit utilization, improvement in documentation, improvement in quality, improvement in case rate mix. So again, really looking at how you're staffing and aligning that with what some of your strategic objectives are. Also, even too, when you're looking at productivity, realigning some of your compensation models around productivity. We always love to give, more money per visit, right? So if someone goes above a productivity, they get more money, right? And what we often pay them by each payroll. Why not change that up a little bit, right? Because what we see sometimes is you have one nurse may go over that, 2 payroll periods in a row, but the rest of the year they're under productivity. Technically, according to the budget, I actually overpaid for that clinician on the aggregate over the year, right? So look at more incentive models that are aggregating data based on a quarterly basis, so represents more of a longer period of time, so that clinician is not just looking at it pay period by pay period, but over the longer period of time. And it also looks at it from a standpoint of, hey, if you look at it a longer period of time, it's less excuses that, there was a snowstorm on Tuesday and, a tree fell down on, 2 weeks ago and I couldn't get out of the house, right? If you look at it over a bigger piece of time, the average tends to work itself out. Even look at it on a team basis, right? From a productivity standpoint, we all work together, right? Nurses pick up other nurses' visits over a period of time. Certain things happen. Some nurses may have more of a difficult, challenging caseload, while others might not. Again, how can you potentially look at that? Maybe incentivize on a team approach productivity. You can incentivize loop up. You can even incentivize value-based purchasing. And then look at how you can improve productivity. Typically, improvements of productivity isn't necessarily just that people don't want to go out there and do visits. It's looking at some of your workflow, your processes, your communication. How are you scheduling? And how are you communicating that scheduling back and forth? And making sure you're as effective and efficient in terms of resources. How are your teams aligned? Too often we see people keep the same teams, the same geography over the last 10, 15 years, but their market has changed, right? Where their patients are, where their staff is. Start realigning some of your teams as well and make it more effective from a scheduling standpoint. So that's from a productivity standpoint. The other area we're seeing a lot of organizations look at is compensation models. If our goals are around quality and productivity, we want to make sure we are incentivizing our clinicians that way. So again, maybe start thinking outside of the box. Most incentive models have only been based on productivity, but can we incorporate some of the value-based purchasing metrics, specifically on a team or even on an individual basis? If somebody use a tool like SHP, you have that data, you have that information, you can actually start looking at maybe quarterly, biannually, or even annually, having some sort of incentive program if value-based purchasing metrics are reached, right? We're only a year off from our first payment year, or a year and a half off from our first payment year. So I think we need to start planning for that now. We want to make sure that we're aligning our goals with how we're paying our clinicians. If we could train our clinicians a lot in value-based purchasing, but if we incentivize them the same way we're being incentivized by Medicare, I think it would go a long way in terms of making sure you're hitting those metrics. And then lastly, we just need to be as efficient and as possible, right? But really what that comes down to is looking at our technology. How can we look at automation from a reporting standpoint? How can we optimize our systems? What are some of the things we can do? If you haven't done a system optimization in several years, I highly recommend looking at ways to utilize the system. Many organizations are using spreadsheets or the good old trusty, I call it, I have one too. I'm guilty. I have a notepad, even though we have OneNote. Notepads or whatever you might have. I know Brian has stickies. I saw Brian's kids actually took out his sticky, were displacing his stickies yesterday, sticky notes yesterday. So, those are the things you got to look at. Is there ways we can optimize it, do it in the system, make sure we're not duplicating, workflow anywhere within our organization. Look at our staffing ratios, really not just from a clinical standpoint, but how are we staffed in our back office? We have the right number of people in certain areas. What we see sometimes is we'll throw everyone at a certain area of the organization and another area is understaffed, and that becomes a new area of focus for the organization. So making sure you have productivity ratios, right? How much revenue should a biller bill? How many insurance verifications should a insurance verification? How many quality reviews should be done on a daily basis? How many documents should be coded on a daily, weekly basis? Those are some of the areas you really want to look at. Do a thorough review of your organization, find out the opportunities, and start building out a project plan to improve those. By improving those areas, you're either saving costs or generating more revenue. It's always that way. It's not just, hey, we're improving. It's not going to have an impact on the organization. Usually means we can take more patients on, we can increase our revenue, reduce write-offs or increase our case weight mix. Or from a cost saving standpoint, is it a way that we can potentially eliminate some costs in some parts of our organization that we have? So again, looking at some of those are really, really important. And then lastly, revenue cycle, right? There's nothing more frustrating. I've been a CFO at a lot of organizations. We all provide great care, right? We do the right thing in the community, right? We go out there, we make sure that those patients are seen timely. We're making sure that we're providing the care that's needed. We know our reputation, our community is at stake, but we do this because we love what we do. But there's nothing more frustrating than not being able to collect for it. As a CFO, it is the most frustrating thing that I've always experienced, is that we can't collect that, the revenue for that care we provided. Look at your processes. Where are there opportunities potentially to reduce write-offs? Is there areas of focus on some outstanding AR from a collection standpoint, especially with increasing Medicare Advantage, making sure you have processes around that, but even from a Medicare standpoint, making sure you're following up on your orders timely, really making sure, looking at those physicians, that, hey, some of those physicians are not filling out those orders and sending them back to us timely. We have to write it off. Maybe we don't want to work with those physicians potentially anymore. Really doing a thorough look at where you want to focus your business operations to make sure you're able to collect on that revenue. As I said, there's nothing more frustrating as a CFO, knowing all the great care we provide, that you have to potentially write something off.
Great information.
So those are some of the strategies we had. Obviously there's plenty more out there, as an organization, but we'll open it up for any questions anyone has.
We have lots of questions, Rob. So I'm just going to start at the top and kind of work our way down. If we don't get to everybody's question, we will do a follow-up email with the answers to these questions. So early on, it was asked, right in the beginning, Brian, is this in addition to the 2% that's already been applied to the 2023? So that we were talking about the cut when that question was asked.
That is correct. Yes, this would be a new cut that occurs effective with 1/1/2024.
Perfect.
So if you look at, they essentially, and there's a lot of math behind this, but took half of that permanent behavioral adjustment for 2023. They're coming back for the other half, and that's actually gotten a little bit more bloated than what we thought it was going to be. But they're coming back for the other half of that permanent adjustment with the 2024 rule.
Excellent. And then in the case mix recalibration, how much have the minimum loop of visits changed?
So actually not a ton. So if you look, the vast majority of those LUPA thresholds are not changing in 2024. I apologize. I saw that question. I was actually trying to pull up the actual numbers here real quick, but I'm not pulling them exactly. I'm remembering off the top of my head, I think there's 20 to 25 that are going down by a visit and 10 to 15 that are going up by a visit, and then another close to 400 that aren't changing. So I could be a little bit off there, but there are not as many fluctuations in the LUPA visit thresholds as we've seen in past years, or as there are changes in other metrics that are going on.
Excellent. And then where can we find the Home Health Wage Index for 2024?
Sure. If you go to the Home Health Agency Center section of the CMS website, so cms.gov, they will list that out, and they will also give you a data dump and spreadsheet of all of the 432 HERGs and the case mix changes. So all the numbers that you saw in terms of wage index and case mix recalibrations and everything came from those spreadsheets that are available right in the Home Health Agency Center section of CMS's website. So you'll basically be able to go find the regulations on there. You can pull it for 2024 proposed and all of the past final rules as well if you want to do any comparisons.
Excellent. Is there any CMS recognition that the decreased utilization is due to staffing constraints and therapy-only cases reflect a nursing shortage?
I'd say minimal. Jnon and Rob, interested in your take on this. There's seem mostly throwaway lines to it, I feel, in the rule that it's, hey, we acknowledge this is going on, but here's what we're doing with the rates. So I think it's something that we definitely need to keep pushing advocacy-wise. I think we'd all agree that that needs to be factored more into what's being done from a rate setting perspective. But I don't know, Jnon and Rob, if you have any other specific thoughts there.
We actually had a nice conversation actually while we were prepping for this, and this was an area we were all kind of surprised about because, obviously we're doing more and more therapy cases because, like you said, the staffing shortage, but also too, that's what's coming out of the hospitals, right? They're asking us to do more and more therapy only cases, right? Because, on top of that, they're discharging the patients sooner because the goal is for them to, be in and out in terms of some of their surgeries. So, it's kind of a lot of irony that they're incentivizing, hospitals and other parts of the healthcare system to get patients to the home setting as soon as possible, which, from the three of us, our opinion, it means that you would have to do more visits in that case because you're getting them more acute or more, less stable than you potentially would have in the past. So, Jnon.
And I would agree that I didn't see much reference to the nursing shortage at all in the rule.
Great question. All right. Is there anything about allowing therapists to do start of care even when an RN is referred? This was a very positive waiver we utilized during COVID in order to get out to see patients as quickly as possible. Staffing issues continue, as we all know. So,
yeah, I would say that no, it wouldn't be in this rule anyway. That would be a condition of participation. And so it would go through a different, avenue than through the final rule.
thank you. And then is it good if CMW index increasing or bad?
So case mix weight, I'm assuming that's referring to. So case mix weight going up is good. That means the higher the case mix, the higher you're getting paid for that P2GM period.
Perfect. Thank you. I was trying to make my acronyms work in my brain fast. There will be a recording of the presentation that will be sent out. So, do we anticipate there will be any changes to the star rating OASIS items to bring them in line with VBP measures?
I've not seen anything to that at this point. What about you guys? Seen anything?
And nah, not as of yet.
Can you explain exactly what the discharge to community claim measure is looking at? Is this where an agency would take a hit for patients who had multiple transfers during an episode, or is it looking at the OASIS item M240 discharge disposition?
So it is looking probably at the claims, since it's a claims data, not an OASIS based measure. And basically it's looking to see if you had the discharge disposition of a 1 or an 81, and also that they have not had a hospitalization, a not planned hospitalization within 31 days of the discharge. So they also have to be alive. They can't be dead. So That is the numerator. The denominator will be the number of home health stays that begin during the 2-year observation period.
Excellent. Thanks, Jnon. Why do most home health agencies avoid Medicare B outpatient therapy?
I think, Jnon and Brian, you can let me know what you think about this. I've actually seen an increase over the last probably 6 to 9 months of agencies going into Medicare outpatient B therapy. Obviously, it's another opportunity from a revenue stream. Also, again, organizations are finding that they have an abundance of, are able to recruit additional therapists on there. And again, I think it goes, every market's a little bit different, but we've actually seen an increase in organizations. And from a standpoint of profitability, on that standpoint, it is a profitable venture. The main reason it's probably avoided is a lot of organizations, it's a very, well, it's from a standpoint of execution standpoint, they can execute it in the market. The billing of it is a lot of the, you have to either maybe invest in a new EMR that specializes in that, or your current EMR might not have that capability to do that. So it does create some manual workaround processes that can become a little bit confusing and disjointed organizations. But we have seen more and more organizations kind of willing to take that risk recently. So
I would completely agree with that for all the reasons Rob said. And I think just, I mean, it is different. I mean, there are some different rules and regulations. I mean, some for good, so some for a little bit more complex there that, I mean, you need to really lean into it and make sure you understand that. It's not as simple as just setting up a new payer in your Part A EMR and just billing that new payer. I mean, there's some differences to it. So I agree with Rob. We're starting to see the conversation and people explore that a lot more, but it's something that you really need to make sure you kind of understand heading into it, even though it does present an opportunity.
Right. Part of it's billing and payer, right? So if they have the copay of 20%, that's a deterrent sometimes also.
Excellent. Thank you. Do you have stats for those productivity measures?
Not sure exactly what part of the presentation that's referring to. Short answer, I guess, is yes. So if you want to email us at the information that's on the screen, we'd be happy to get you whatever specifics you're looking for. I know Rob was talking about all of the back office. I mean, both the clinical and non-clinical, but really looking at the non-clinical operations and productivity there. We do have benchmarks for all of those, and that we look at for productivity in both staffing those functions. And we'll be happy to share with anyone if you want to follow up with specifics.
And those should be really important as you kind of start to build out your budget. You really need to start looking at those measures and holding folks accountable. Too often we hold for years and years we've held the clinicians accountable to productivity, but we don't hold our back office in terms of that. Sometimes we just we may add staff unnecessarily because of a feeling and not a number. And I know I'm a numbers guy. I got a CPA. I do have feelings. I'm a blue in terms of personality wise. I do have feelings, but yeah, when it comes to the budget, it's a numbers game in a lot of ways, right? And what you don't want to do is you don't want to just be inefficient or just feel like, oh well, this person tells me they have a lot of work to do, but maybe they don't have a lot of work to do, and maybe they can process it. And it's not necessarily that person isn't good at their job. It just might not. They don't know how to use the tools, how to use the EMR. Training and education is the utmost important. We don't all just, wake up, one day or go, especially in the back office standpoint. You don't, and even as clinicians, right? You learn home care kind of as you do home care. It's not something that there's a book for it or textbook or education and anything at that standpoint. So you really have to make sure your staff is trained up on a lot of these areas.
Excellent. And then one last question, and then we have some more questions, but we'll answer those offline. Are most Medicare B therapy lucrative only when done in a congregated setting?
I'm guessing they're referring to an ALF, and I would say the pay's the same. Where you're going to run into more difficulty is mileage. So obviously in an ALF, you're not going to have that mileage factor.
Excellent. Thanks, Jnon. And then we had a couple. Oh, sorry, Rob.
You can also use more assistance more readily as well, which is another thing in terms of that. And then it could be, but there could be some challenges in terms of the skilled requirements and things of that nature. So I have just we have a person on our team who's been pinging me all Medicare, my Medicare Part B as we go through this. So big shout out to John Robbia. Thank you for all your notes. He's our Medicare Part B expert. So
Excellent. And we'll just answer one last question here, and then the rest, I promise, we'll follow up in an email to you because these are great questions. But what is the Compass program, Brian? Would you want to touch upon what Compass is real quick?
Yeah, sure. This is part of, I know Rob referenced looking at technology optimization and the tools that you have available out there. One of the pieces specific to visit utilization. I mean, you want to look into what's available via your EMR to do that, but there could be some third-party platforms. Compass specifically is one that SimiTree offers that allows you to look at visit utilization over a 30-day period, 60-day episode. It's one of several tools that are out there, but I mean, the main message is look at what's available and make sure technology is working for you. I know specifically with the Compass side, we've heard from a lot of clients that has allowed them to really tee up their care plans at the start of care and understand where they may be overutilizing, has even allowed them to open up and see more patients because they're able to use the nurses, the therapists more effectively. So it's one avenue to go in that make technology work for you and make sure you're using it for those cost review measures.
And I will say that, if anyone wants to reach out to me and wants to have a demo, I'd be happy to do it. I help Christy a lot with demos for Compass. I think there's a couple of questions about Compass in there.
And
For sure.
And it's great stuff. It's a tool to use for your clinical managers. I mean, it's becoming more and more challenging, on this. So I mean, any tools you can give them, not only is it great from a standpoint of results, but even from an added benefit for the organization, it's really good data. And again, people aren't just guessing, right? Sometimes organizations, you're just guessing, or you're just looking at your internal data. It's good to have that national perspective.
Excellent. Thank you all so much for attending today. I know there was a couple of questions that I put in there that we'll follow up in an email. So we really appreciate your time and attention. As always, if you do have additional questions, Jnon, Rob, and Brian's information are all listed out here. Please don't hesitate to reach out to any of us. Within the next 72 hours, you should get a copy of the handout and the recording. We are glad that you could join us today. Again, have a wonderful afternoon, morning, wherever you are. And we appreciate your time and attention. Thank you, Jnon, Rob, and Brian, for a great presentation.
Thanks, Missy. Thanks, everyone.
Thanks.